The latest installment of Phoenix Children's Live. I'm your host today, Peter Ballestre. I'm a brand manager with Phoenix Children's Medical Group. With me today is Dr. Verena Barwinkle. She is the medical director of Barrow Neurological Institute at Phoenix Children's Hospital Neurocritical Care Program. It's a lot of words, but it's a great program that we have. So thank you for being here with us today.
Thank you for having me, Peter.
Yeah. So before we start, real quick, as we always say, while we're live, you can ask questions to us in the comments, and we'll try to get to those as soon as we can. Otherwise, when the episode is over, we'll answer them afterwards as best we can. While you're watching, throw us a like. Let us know you're out there in the audience. A love would be great too. We don't mind those. But let's talk about neurocritical care today. So the big opening questioning will be, what is neurocritical care? What does it entail?
Well, Peter, neurocritical care is the specialized care of children who have very serious neurologic disorders and typically are being cared for in one of the ICUs of the Phoenix Children's Hospital. So that would be the pediatric ICU or the cardiac ICU or the neonatal ICU. Sometimes we do go down to the emergency department for children who are recognized to have a potentially serious disorder and see them immediately as well.
Okay. So is this the timeline of neurocritical care? Is this a newer area in the medical field, or is this something that's been around for a long time and it just got a new name, or kind of what's the background on neurocritical care?
So neurology itself is actually not that new of a field. It is a new field, neurology, and then neurocritical care itself is a new field even for adults. In the last, I would say, decade, neurocritical care developed for adult care, and in the last 5 years we've started developing a specialty only for children and neonates. And so I've been in this field since 2012, and there isn't even a training program yet established for it. There's small fellowships in very few cities of the United States, and so the number of dedicated providers is extremely few across the board.
Okay. So when you talk about neurocritical care, you mentioned it briefly, it's not only emergent or for emergent situations. It kind of runs the gamut in a lot of different areas, right? So what's the difference between the emergent portion of critical care or neurocritical care and the non-emergent portion of neurocritical care?
Well, probably the first thing that comes to mind is separating the two is any new patient gets triaged immediately as how quickly do they need to be assessed. So any new question that comes to the neurocritical care service, they get triaged, and as far as who will be seen first, second, and third, but patients who are following up care, who are doing better, of course, they're less urgent to see right away. But there are definitely problems that require neurocritical care attention that in and of themselves aren't emergencies, but require very close attention and monitoring.
Yeah, and that's hence why it's so important to talk about that Phoenix Children's Hospital has a dedicated neurocritical care program. That's kind of non-existent across the United States. I mean, we're one of very few, right?
A small handful.
Yes. What are the benefits for our children here in Arizona to have this dedicated neurocritical care program here right at Phoenix Children's?
So neurocritical care programs across the board show that we have optimal outcomes for our children that receive this type of care. So the providers dedicated to the neurocritical care team aren't off in their clinics and then when they can become available go see a patient. These are providers who themselves, their careers are dedicated toward the study and care of these children and their particular problems and knowing what to anticipate for them. So the bottom line is better outcomes for these kids.
So team-wise, you're the medical director, but and this might be a growing team. So who makes up the PCH neurocritical care team at this point?
Right. So of course myself and Brian Apavu and Iris Marcu. So Brian Apavu is a recent addition who came in the last month, and he's an epileptologist and neurocritical care specialist. And he and Iris Marcu, who's our dedicated neurocritical care nurse practitioner, are the core team, and then of course we have dedicated fellows who are already pediatric neurologists, just like 1 year away from their completing training, who will shadow us along and help care for those patients.
Okay, so bench strength that way.
Yes, that way.
Yeah.
The overall plan is to bring in approximately maybe about 2 more providers, so that we have a core team that's available around the clock, and that's going to be happening within next year.
Okay, that's excellent. So, we talked about the emergent, non-emergent, but maybe for the non-emergent, when we talk about referrals and all of the pediatricians across the state, maybe even in the landlocked states to Arizona, why should those pediatricians, those doctors, refer to the neurocritical care program here at Barrow at PCH? What are the benefits?
So these providers that care so much about their patients want their patients to do as well as possible, and often these are general providers who the last time they participated in direct neurological care was back in medical school. And so they're seeing signs that there is probably, or could be, or might be, a neurological difference in this child. And for them to understand what is the severity right off the bat would be unreasonable to expect that. But if they refer to our hospital, they can know that no matter how bad it is, how serious it gets, whatever, we can handle it. And in a timely manner, so that child will have the best outcome. So when that parent calls back to that provider, they're going to more than likely, than if they went somewhere else, have good news and praise for that provider for sending them to us.
Well, and you mentioned this in previous talks we've had. Neurocritical care, it seems like a no-brainer, but the faster the better. It's the timeliness factor. And then I remember you saying something to me about that if you're a parent, even a provider at this point, if you have even an inkling or a red flag, something should be done. And it's okay if it's nothing. At least you've done your due diligence. So talk a little bit about that, because I think you probably see that quite a bit in your career. Yeah.
So I'll tell you right off the bat, parents know their kids best. Nobody knows a kid better than a parent. They know something's a little off, and I'll tell you the first thing I'm listening to in the morning is the parent's report. And the nurses, the doctors, care team, everyone. But what is that parent? How do they think their kid is doing? And so when they have a concern, I'm paying attention and I'm taking it very seriously. And so when a parent's at home with their child or they're at the pediatricians, they are the #1 advocate of that child and should be taken very seriously. And so when they're coming in and they express their concerns, those are the subtlest signs that something is different before a catastrophe happens. And really just instilling in those, first care providers, which are the parents and the primary care providers, that listen to yourself. If you think something's wrong, then it's worth at least the most experienced hands take a look at this and just see what you think.
Yeah.
Worst case scenario, the worst case scenarios is like everything's fine, and here's where to follow up with that.
Perfect.
Or thank goodness you referred because you saved this kid's life, or serious neurologic disaster could have happened. And we see that, so it's very real.
Probably all too often.
Yes.
Yeah. So let's talk about maybe what are the most common symptoms. And I think in doing research on neurocritical care, that's part of the problem. Is it's some of these things are very subtle, as you were saying, and as a parent you should know your child. But what might be some of the symptoms that would raise a red flag for a neurocritical care complication?
Yeah. So I'd say first off the bat is something unexplained about your child's mental status. So what I mean by mental status is how alert they are. Are they responding to you in the same speed and manner that they normally would? And if they aren't, if you don't understand why, then that child needs attention right away. Any child who used to walk and is no longer walking, or part of their body isn't moving as well as it used to, should get attention right away. A child who had clear speech but now has garbled speech, that's very concerning. So how sleepy they are, how their body's moving, these things can be signs that a serious neurological disaster is impending. Okay.
So let's talk about stroke, because stroke is actually one of the areas that fall under neurocritical care, pediatric stroke. Can you talk a little bit about our stroke program and how neurocritical care kind of fits into, or puzzle pieces into that?
So as the medical director of the Neurocritical Care Service, it is my job to ensure that we are achieving the best and most excellent stroke care possible for children. And so that starts all the way from the door of the ER up to the ICU, and all of the interventions that are the most advanced possible are available to every child, and they are examined and intervened upon in a timely manner, because time is brain when it comes to stroke.
Yeah, we've heard that before. That's really great. So that would be almost one of those emergent situations with stroke.
Oh, definitely. It is emergency, for
yeah,
sure.
Yes.
Mm-hmm.
I think still a lot of people, myself included, I will admit, I didn't even realize maybe until about a year or two ago that kids could get strokes.
Mm-hmm.
You know, that was pretty amazing in of itself. Is that still uncommon knowledge for a lot of families and parents?
Relatively experienced medical providers don't know that.
Yeah.
And or it isn't on their on the front of their mind if they're seeing a child who might not be walking.
Mm-hmm.
So it can be confusing to providers who haven't thought through that recently.
Yeah.
And so having a low threshold for referral to a center such as ours that takes care of stroke, which we're the only one in the whole state of Arizona that has a dedicated stroke program just for children.
Yeah.
That could be the difference between life and death for that child, or serious permanent disorder.
Yeah.
Mm-hmm.
So let's talk a little bit more about stroke. I mean, which kids are at most risk for
Mm-hmm.
pediatric stroke? Is there a striation, a group of children that might be at higher risk?
So first of all, comparing to adults,
Mm-hmm.
For every 100,000 people, about 200 adults of these 100,000 are going to have a stroke in their lifetime.
Wow.
So compare that to children who are greater than a month of age. About 13 per 100,000 are going to have a stroke.
Okay.
Children.
Okay.
And this is, so imagine how many 100,000s are in the Phoenix area alone.
And it's growing.
And then you start counting that out, and those are the number of children this year alone that are going to have a stroke.
Okay.
Then you look at infants who are born on time. About 40 of those per 100,000 is going to have a stroke.
Wow.
Mm-hmm. Now, raising the stakes even higher is that if it's a premature infant, about 100, so that's about as half as the entire risk of your entire lifetime is happening at the time of birth if you're a premature infant.
Wow.
So we'll have a stroke. And children, unlike adults, are going to live their entire life with that deficit that they occurred from that stroke. So an adult had their whole life to have a meaningful, fully functional lifetime, and then the last X number of years they have this deficit. Well, that child's going to live with that their entire life.
Yeah.
And their chances of survival are about 2/3 higher than adults. So the chances of them surviving with a deficit is very high. About 50 to 60% of them are going to have cognitive deficits, and 50 to 60% are also going to have serious movement differences from normal.
Well, and that's back to what you were saying, the time is brain, and being aware of those kind of symptoms if you're a physician or a pediatrician and a parent as well. Another group that is so key in this that we work very closely with is the EMS in Arizona. Talk a little bit about what their role is and what they can learn from you guys in terms of this kind of approach with neurocritical care that we offer here at a quaternary hospital such as ours.
Yeah, so the first thing I would want to say to all the EMS providers out there is thank you for the excellent care that they're providing. And they are the first triagers. They're the ones who are making decisions on the fly about where should this kid go and who should we contact, and following those directions and doing their best for the child until they can hit the ground here at an emergency room where the doctors are going to take over from there.
Right.
And so we are a level 1 trauma center here at Phoenix Children's, which is not something that other centers can say.
Right.
So that means we have the most advanced, complete care that any child with any problem, any neurotrauma could possibly need. We have it. And so that's backed by the Neurocritical Care Service as soon as they hit the door, and maybe even before, because we can be called from EMS in the field and help guide them all the way in.
Let's talk a little bit about that too. So you're at your desk, you're rounding, whatever it happens to be, and you get we get a patient that comes in from EMS.
Mhm.
Talk a little bit about how you get called in, or what kind of the process of how you get yourself involved when in an emergent situation like this,
Mhm.
when an EMS group brings them in.
Yeah.
I think that's important.
Right. So the neurology department offers and is available 24/7 coverage of that emergency room. A neurologist is there picking up the phone and answering those questions, and then can be immediately available at any time to help take care of that kid. And the neurocritical care service is evolving over time to develop a 24/7 program as well. Right now, we're still a Monday through Friday service, and then available for questions through the weekend.
Wow.
But the neurologist in our department is taking care through the weekend.
Yeah.
So continuously, they do have care.
Yeah, yeah. One of the other things that you talked about before, it really struck a chord with me, was a child living with something that may have happened, a neurocritical complication, because they end up living longer. I think I read that babies' brains have more plasticity. They have a little bit better chance to heal. So then they live a longer life with maybe these cognitive dysfunctions and things like that. But I also read that, and you told me as well, that the most common neurocritical complications are from difficult childbirths,
Yeah.
the neonatal neurocritical
Right.
complications. Let's talk about that, because I think we could almost do one whole Facebook Live on that.
Yeah,
but I think this is
truly.
really important to talk about that, because for mothers and fathers to be, it's important to know if your birthing center would send them here or not,
Right.
for the reasons that you're going to talk about
Yeah.
right now.
And I think, what you just alluded to is that whether or not that birthing center would refer to us
Yeah.
can be easily glossed over. I mean, giving birth, the environment that they're in, having, care for the mother, all of that, is of course a very important focus to the family. And then what might not be pointed out to them is that, guess what, we won't refer to the highest level of care, or it'll take a lot before we finally do. And centers that have a very low threshold for referring to the highest level of care means that even if your child has a very simple neurologic problem, or might,
Yeah.
then if they have a low threshold for referral, then more than likely your child is going to get care sooner in a more timely manner than later, when it may be too late.
Yeah.
Or suboptimal timing of intervention.
And like you said too, you don't want to, as new parents, probably the last thing on your mind that something bad is going to happen. You want to just be in the moment and things like that. But being a planner, if that's something that you are thinking about, you should ask those questions of your birthing center. And then definitely, of course, if you're at a high risk birth possibility already. I mean,
Right.
that has to be kind of first and foremost, I would
Right.
imagine, right
Right,
there.
yeah.
So quickly, as far as this being the most common, what kind of cases or complications do you make it the most common? The neurocritical complications make this the most common in terms of neonatal.
Sure. So the terminology, the medical terminology for the most common birth injury is called hypoxic ischemic encephalopathy. And over the last several years, the treatment for this, which is essentially low oxygen level to the brain during time of birth. So if you will, all children, all of them, during the time of birth, have a short period of time where they're not receiving oxygen to their brain.
I didn't know. Okay, so that's
Yeah, so you add any complicating
Wow.
factor to that birth. A large head of a baby, a small pelvis of a mother, the mother has a fever.
umbilical cord, maybe
Umbilical
too?
cord,
Okay.
any number of, just during a normal delivery, and the chances of that child having lack of oxygen beyond the point and permanent brain damage start growing exponentially.
Wow.
And so during the time period just after birth is the most critical time of care for that child's brain, and preserving as much brain function as possible can occur during interventions such as cooling to the brain and the very best seizure control possible,
Yeah.
and watching out for bleeds in the brain that can happen afterwards as well,
Yeah.
and swelling of the brain itself. So having these highly specialized services, rather than someone who might just be familiar with the first step taking care, or might not understand how complex this particular case is until it's too late. So having that low threshold for referral of these children who might have, even maybe not have, but might have sustained a neurologic injury could mean a big difference in that child's life forever.
Forever, right. You mentioned you as the medical director and your team would probably be working with a lot of the ICUs here. The NICU obviously is going to be probably a group that you work with quite a bit, and with especially this kinds of situations that you talk about. How can someone expect that you would intervene or work with, collaborate with our NICU with these kinds of situations?
So the NICU consults our team as soon as any child with a concern for a neurologic difference comes into our ICU, and we see that patient directly, communicate with the families and the ICU team directly, and help take care of that child on a daily basis, so long as there's any concern still going on with that child directly.
Is there any more that you can offer on why a baby's brain has the ability to heal? We talked a bit about that is the organ that is the hardest to heal. Other organs have an ability to heal a little bit better, but the brain isn't. But a baby's brain has the ability to a little bit more. Can you talk a little bit about that? Because I think that was pretty. When I read that, I was like, oh, that's actually really interesting.
Yes. So babies' brains are different than brains at any other point in life, and their pattern of oxygen usage is completely different than any other time of life. And so understanding the most vulnerable parts of a newborn's brain is critical to understanding how best to intervene for that baby, and understanding the patterns that you would see on, say, imaging differences for that baby could be subtle between, say, this was a hypoxic difference versus a loss in blood pressure versus a blood clot is in this child's brain. And each one of these would need a different intervention and a different workup. And so, how that baby's brain will then heal depends on which injury did they have. And helping the family anticipate that. And families are often in just a crisis mode when their child is that sick. And as much as possible, understanding what is exactly going on with this complex issue with their child, letting them know what the next few hours, the next few days are going to look like, and the next few years can allow them to relax some and just focus on the healing of their child, which just helps the family tremendously. You can see it.
And again, I'm going to keep saying this, and I'm sure you say it a lot too, the earlier the better. Time is of the essence when we're talking about neurocritical complications like this, especially with babies like that. So, I'd say that over and over again. One of the other areas of neurocritical care that dovetails really well into our programs here is epilepsy. And in reading your background too, and having kind of the resting state, the MRI resting state background, let's talk a little bit about how epilepsy and neurocritical care kind of merge together, and what your team and you do from that standpoint in terms of epilepsy care.
So first and foremost, our number one consult is seizure. So seizures is what I take care of all day long. And seizures come in all sorts of flavors. This could be a child with a new onset seizure, could be a child who has established epilepsy but deterioration in the control of their seizures, or could be a very sick child who's seizing from a cause in their body affecting their brain function. And then also, so we're taking care of all of these types of children who are having seizures, and understanding which medications, how much, how often, what type of monitoring, and handling all of that is what we do day in and day out. And even the most complex cases, which are seizures that can go on for weeks at a time, and understanding how best to dose agents that induce coma, or even escalate to a surgical cure for that child in a rapid manner if needed, is available, and we're used to doing that escalation process.
So you work closely with Dr. Wilfong and Dr. Adelson.
Oh, absolutely.
So and that's really the big part of our program, is that, again, you are dovetailing, collaborating, so that this continuum of care is happening. Right.
Yes. So we have an very highly experienced epilepsy team who around the clock are monitoring EEGs, which monitor brain waves, detecting to detect seizures in case they would happen, and calling in our service to help treat those patients in their complex seizure patterns.
the other thing that we just came out of August, and it was drowning impact awareness, and I think that even kind of fits into the neurocritical care, right? Because loss of oxygen to the brain immediately becomes almost a critical care impact situation. Can you talk a little bit about that too?
Yeah. So drownings are very unfortunate. Here we have most likely a normal child who went through a period of time where they weren't receiving oxygen to their brain, received CPR, they were revived, and they come to the ICU. And it's the job of the neurocritical care team to make sure we are doing everything possible in a very timely manner, that we are preserving as much brain function for that child as possible. And at times that could mean that the lung injury that's going to happen after a drowning, we help them survive through that. So then what we can from the rest of their life, they have the best outcome possible. So children who have drowned, essentially, if it's been a very long time and a very long resuscitation, oftentimes it can be very difficult care after that, as opposed to the ones who received immediate resuscitation and come in. So these are these two groups that we are very experienced in helping them through the entire process. Yeah,
definitely. All right, one of the last things I wanted to talk about too, because we are kind of going down a path of making a comprehensive ortho and neuro spine center, and I think neurocritical care would be another big part of that as well. You guys are part of everything, it seems.
If it's neurology to the ICU, we're here. Yeah.
How does neurocritical care fit into a comprehensive spine center?
Yeah. So we are very much looking forward to the opening of the comprehensive spine center and being an integral part of that. I would say that first and foremost, the neurocritical care service is here to provide detailed examination over time of any child with a spine or concern for a spine disorder. So these would be children who could potentially have had a stroke of their spine or a lesion in their spine, such as a cancer or a demyelinating disorder, so the immune system attacking the spine, and providing very timely care for those children. The spine itself takes care of being able to breathe independently, being able to walk, being able to use your hands, being able to use the restroom independently. The spine is critical for all of the communication that comes from the brain out to the rest of the body, from the body and back up to the brain. The spinal cord of a child can be anywhere from less than the width of my pinky to my thumb. It's a very small structure, the spinal cord of a child. And a very dedicated, experienced team is what any parent would want for the best outcome for their child's spinal cord. Peter, I'll give you an example of a normal teenager who came into RER. She was referred from an outside ER because she seemed to not be able to move one of her feet, lower leg very well, and she had some mysterious complaints that they weren't sure quite what to make of. Should they send her home? But they said, just to be on the safe side, we'll send her over to PCH. They sent her over to PCH. I hear what's going on with her and examine her immediately. Upon seeing her exam, I personally escorted her right into the scanner. We got a spine image right away to make sure she didn't need immediate neurosurgical intervention. And then because the lesion that we saw in her spine transversed several levels, could have been a stroke or could have been a demyelinating disorder. Immediately, we escorted her straight up to the angiogram suite, made sure she didn't have a blood clot in the artery to her spine. She did not, and then immediately she started receiving the triple therapy that rescued her spine. She's walking today. And most children with that would not have left the hospital alive.
PCH, folks, Dr. Borwinkle. See, this is why we do this. This is why we do these kinds of things, and we want you guys to understand the level of care and the expertise that we have here, and having this dedicated neurocritical care program is huge. So thank you again so much for being here today.
It was a pleasure.
As well. Again, throw us a few likes, a few loves. She gave us some great information today, and we'll see you for the next Phoenix Children's Live. Until then, take it easy. Thank you.
All right.